Let's talk about hypoglycemic agents for the treatment of diabetes, and we'll talk about high yield points which are tested on USMLE. Let's start the drug with metformin, and its mechanism of action you need to remember is it increases glycolysis and decreases gluconeogenesis. It is used only for type 2 diabetes mellitus, and as a side effect it causes lactic acidosis, and you need to discontinue if bicarb is low, which means lactic acidosis, and you need to discontinue if the create is 1.5 or greater, as it is a marker for the reduced renal function and which is a risk for the lactic acidosis. During pregnancy or intrapartum, you need to choose insulin over metformin for the regulation of glycemic control, as it allows for optimal fine tuning and control of the glucose levels. Now, USMLE can give you a patient on metformin who have to go CT with contrast and eventually ends up getting high creatinine, and they would ask you how would you have prevented the increase of the creatinine prior to the CT, and your answer should be infusion of 0.9% saline or the adequate intravenous hydration. And the most common wrong answer which everyone usually gives is the discontinuation of metformin. This is very tricky, where you need to know that adequate hydration with the saline is number one way to prevent contrast nephropathy. There is increased risk of lactic acidosis due to metformin in patients who have renal insufficiency, but metformin itself does not cause renal insufficiency. So, to put it better, increased creatinine is a reason to stop insulin, but increased creatinine does not result from insulin itself. It's a little tricky to remember. The other drug is sulfonylurea. The drug could be the examples of the drugs are glyburide, glipizide, glibenclamide. They are usually known as insulin secretagogues. That is, the insulin increase there is increase in insulin secretion by blocking the ATP gated potassium channels on beta islet cells without the need of for the ATP. Now, gluburide and glipizide are the one that repeatedly shows on USMLE, and they just want you to know the side effect, and one of the major side effect that they could cause is severe hypoglycemia. The other drug that could be tested is miglitinide. The example of the drug is repelglanide. It is similar to the sulfonylureas, which are the insulin secretagogues, which means there is increased insulin secretion by blocking the ATP gated potassium channel on beta cells without the need for the ATP. The other two drugs, that are the GLP-1 analog and DPP-4 inhibitors, kind of similarly works together. The GLP-1 analogs are liraglutide, semaglutide, and they are the glucagon-like peptide one which stimulates insulin release. And the major thing that they do is that it suppresses the glucagon secretion, as well as they slow down the gastric empty and promotes the satiety, and thereby preventing rapid increase in the postprandial blood glucose, and they also decreases appetite, which can eventually lead to weight loss. DPP-4 inhibitors examples are sitagliptin, and DPP-4 is an enzyme that breaks down GLP-1. So if we inhibit DPP-4, GLP-1 is raised, and therefore increase in insulin release from the pancreas. The other drug is thiazolidinediones. Example is pioglitazone. It increases insulin sensitivity at tissues by stimulating PPAR gamma. And the side effect you need to remember here is the liver toxicity. And the other drug, alpha glucosidase inhibitors, example acarbose maglitol. It decreases glucose absorption in the small intestine, and while it is an absorption related mechanism, it as a side effect it can cause GI disturbances like the diarrhea. And the last drug I want to discuss with you is SGLT2 inhibitors. It is the example is dapagliflozin. It decreases glucose reabsorption in the proximal convoluted tubule of the kidney, and therefore there will be increase or the you can say increased excretion of the glucose in the urine, and that's why as a side effect it has increased risk for candidal infections. These were the hypoglycemic drugs. Let us discuss one or two points regarding insulin. And insulin, usually USMLE wants you to know about the insulin, and I will discuss one or two points. One of those is they give you a patient with diabetes who wakes up with severe hyperglycemia and ask you what needs to be done, and the answer would be in decrease, not increase. Please remember, decrease the dose of evening intermittent acting insulin, not increase. And why is so? Because there is a phenomenon known as Somogai phenomenon, where it appears as though because morning glucose level is elevated, which means night or the evening insulin is insufficient. But that was what we presume, but it's actually the opposite, where evening or night dose is too high, which pushes the patient into overnight hypoglycemia, causing a compensatory sympathetic response that results in a robust rebound hyperglycemia by the morning. So this is very important point, that whenever they ask you what need to be done next, you need to decrease the evening dose, not increase, decrease, because of the Somogai phenomenon. The second thing which they would love to test you would be, they give a patient with type 2 diabetes who is already on metformin and the gluburide, who has uncontrolled HbA1c at 12%, and give you either low bicarb or the high create, and they ask what needs to be done next, and your answer should be discontinue metformin and gluburide and start the intermittent acting insulin. Now there could be 2 points which I want to discuss here. Is if a patient has low bicarb while on metformin, this means it is lactic acidosis due to metformin, so you must choose an answer where metformin is discontinued. And a patient who has creatinine 1.5 or higher needs to be off the metformin, which we have already discussed the point above. So this is all about the hypoglycemic agent which usually is tested in the USMLE, and hope this was helpful. Thank you.